with everybody who might not have been able to come to our breakout room. Then let me just share my screen, pull up our PowerPoint, if I can find it. Sorry. All right. So good afternoon, everybody. Let me put this in PowerPoint mode. Thank you for joining us in our Preventing Suicide Among Military and Veterans, a Clinical Approach. I was just going to introduce our presenters today, Miguel Ocegueda and Jim McDonough, who both work at Headstrong, and I'll let them do their own introductions. And then just before we get started, if anybody has any questions throughout, please feel free to use the chat feature. But please try and stay on mute as much as possible, just so we don't interfere unless we are having a conversation, obviously. So without further ado, I'm going to let Jim and Miguel take over, and I am going to stop sharing and let them give you the good stuff.
All right, thanks, Melissa. Hello, everyone. I'm Jim McDonough, and I'm joined today by my partner in crime, Miguel Ocegueda. And for the next 50 minutes or so, we're going to try to engage you in a discussion on what it's like to deliver mental health treatment to America's veterans and their families from a community perspective. And that community perspective we're going to offer you is that of Headstrong, about an 8-year-old nonprofit that stood up in the thick of these wars to address the mental health needs of returning veterans and their family members. And we're going to kind of divide the conversation up into about 3 major parts. One, we want to make sure that we describe for you adequately, what is Headstrong? What are the treatment modalities? What's the model of care within? And then we want to talk to you a little bit about some of the current challenges and trends that we're seeing in the mental health treatment for the clients that we support month over month. And then we're going to end the conversation with a little bit on the future of integrated care and services for members of forces and veterans of our armed forces going forward in life. So 3-part conversation. We're going to leave time at the end for Q&A. And as Melissa said, if you'll drop them into the chat, it's probably the best way we can use to manage the information. But first and foremost, we want to thank you for joining. We are, in fact, a partner of Every Mind in the Washington, D.C. metro area. Headstrong's been a provider within their network for some time now, delivering treatment in community settings in and around the D.C. metro area. So I'm a 26-year veteran of the active armed forces, served in the United States Army. Upon retirement, I've been kind of leading a couple of different organizations addressing the needs of America's veterans, including nonprofit organizations in Rochester, New York. Spent a lot of time at Syracuse University's Institute for Veterans and Military Families. And then I've done a couple of tour duties as the State Commissioner of Veteran Services here in New York State. So I'm going to pause there and turn it over to Miguel, and we'll get into the conversation. So Miguel.
Hey guys, good afternoon, and thank you for taking some time in this busy Thursday afternoon to just hear from us and what we're doing. My name is Miguel Ocegueda. I am the Deputy Director for Business Development and Programs. I'm a 13-year Army veteran. I was a combat medic, did a few tours to Iraq and Afghanistan. And, after leaving and exiting the military, I spent some time really devoting myself to ways that I could improve vulnerable populations, especially around mental health in general. I do have an MPH from Syracuse University. And most of my work has been around helping promote, health initiatives for vulnerable groups. And I believe veterans to be one of the most vulnerable, especially given their ACE history, their prevalence for suicidality and PTSD. So I'm happy and honored to be part of this conversation and to share some of the insights we've been able to garner over the last few years. But I'll pass it back to Jim.
Okay, thanks. Thanks, Miguel. All right, folks, so settle in. So the first thing we're going to talk about is, what is Headstrong? What is the model of care associated with Headstrong? As I said at the top of my remarks, Headstrong is about 8 years old at this point. And it was formed by a returning Marine who had a pre-existing relationship with clinicians at Weill Cornell Medicine. And our founder, Zach Iskel, served in some really tough spots in the United States Marine Corps in the early days of these wars. And he came back, and his seminal kind of observation was that upon coming back, he was losing more friends, more colleagues in the United States Marine Corps after their tour of duty was up due to suicide than what he witnessed in combat with his fellow Marines. And he was struck by what he was observing. And remember, you don't have to think back too far to include today's kind of daily look through life in terms of like the stressors on families, what's associated with post-military service. And you clearly see that 8 years ago, there was an organization that stood up to address really the rising rates of suicidality amongst those who serve their country. And from that kind of initial visioning and the partnership with Weill Cornell Medicine, Headstrong began its care delivery model in New York City. And if you fast forward now to 2020 and soon 2021, we're now resident in 28 different program communities across the United States of America. And we will open up a new market in Seattle, Washington, right after the first of the year. So what was once one effort to address the needs, the mental health needs of returning veterans in New York City, has quickly grown over the last 8 years to kind of address these needs at a more wholesale level across the country. Our plans include expansion into all 23 of the VA's veteran integrated service networks. There are 23 in this country. We're resident in 11 now, and we'll talk about COVID in a bit. But one of the silver linings that we've discovered within the COVID-19 pandemic is that of telemental health and how it offers us more reach, especially to really underrepresented populations of the veteran population in this country. And the ability to kind of deliver telemental health at scale is certainly part of the Headstrong model itself. Within the model, it's very unique. We have about 250 to 260 practicing clinicians across those 28 program communities. We do not spend money on facilities or brick and mortar. We spend money directly on our clinicians who day over day, month over month, year over year are serving the ongoing mental health needs of about 1,000 veterans and active duty service members and their family members month over month in this country. And so that group of clinicians are overseen by our team at Weill Cornell Medicine, our partner in this work, who are responsible for clinical supervision, clinical oversight, the vetting of our providers, et cetera. So it's a fairly interesting model. It's unique in my observations of the last 13 years since retirement around community-based care. We'll talk about trends in care in a moment, but I'd like to pass the baton back to Miguel to take you through our three-step process and the treatment modalities that are offered within Headstrong itself. So Miguel, back to you.
Thanks, Jim. And so anyone, please feel free to sort of raise your hand or intervene at any moment. I'm going to throw a lot at you in terms of information, so please feel free to just pause. So I think I wanted to just add a little bit of contextual history to a little bit of what Jim was saying, back in 2012. First, making sure that, part of what Headstrong did in the early days was take a look at existing trauma treatment modalities being offered in this space. Among them, very popular and well-known, slowly working and integrating their way into the VA was CPT and PE. EMDR, of course, was also sanctioned by the DoD, but it was lesser integrated, less well-known because of sort of the lack of larger scale studies that included veteran populations, but its efficacy was demonstrated in a couple other settings and institutions across the country and across the globe. So in initially wanting to address what we were seeing at the time being was this onslaught of veterans who had demonstrated poor treatment adherence or had come from a variety of other different mental health settings, having received treatment. A lot of the veterans that we were receiving initially were not naive to treatment. They had already gone through a couple of these either IOP programs that really emphasize on stabilization. So they took a lot of sort of a deeper dive in what were some of the existing trauma treatment modalities. And the way they came up with the model, rather than focusing on putting veterans through a series of either, one-offs with CPT or PE, and looking at what was actually happening to the veteran as a whole. What they decided was to land on a model that not only addressed sort of the exacerbation of PTSD symptoms, so essentially moving away from the intervention of just stabilization alone, but treating the actual, not just what's contributing to the trauma, but what are some of the things that are happening around the veteran's life that are exacerbating a lot of these symptoms. So, we landed on, really favoring EMDR from a clinical perspective. Not that it was the only requirement, but on a whole, we saw that it was a little bit more palatable to some of the veterans who were experiencing some of the hyperarousal symptoms. It was easily digestible, but more importantly, that it was also, it had an ability to address pre-existing traumas prior to service. So a lot of the comorbid conditions with complex trauma that were coming up in the veteran population, they felt that EMDR was a more softer and more palatable approach to addressing this. So keeping that in mind, in addition to that, what they looked at was, rather than treating just a period for stabilization, what they wanted to do was do the entire arc of treatment. So rather, for them, it was important to adopt the Judy Herman model for trauma recovery, really focusing on some periods, a brief period of stabilization, but also doing the bulk of the work in the actual traumatic memory processing. And then lastly, working with them through reintegration. And at each and every one of those, at those steps, for them, it was important to utilize evidence-based practices at each. So a lot of how we choose and vet clinicians has a lot to do with the skill sets that we see are sort of effective at each and every stage of the trauma recovery process. So for stabilization, for instance, a lot of our clinicians do have some DBT skills. They work a lot with mindfulness. They work a lot with, teaching breath techniques. And then for the traumatic memory processing component, for them, it was critical to not only use EMDR, but also have CPT-PE. Whatever was working for the veterans currently in our care, they had an option to choose from this wide array, and more importantly, tailor treatment to making sure that their needs were being met. And then lastly, for reintegration, part of the critical and secret sauce for Headstrong is that once they're done with trauma treatment, for instance, they're now equipped with a new body, a new nervous system, but many of them don't know how to, again, reintegrate back into life. There's adjustments with their family systems. There's adjustments with work, with school. So a lot of the work for us also, we see that it being sort of long-term and helping them reintegrate. And that's part of what's been so critical to Headstrong's success here. We don't place a limit on the number of sessions for that reason. And so veterans are here with us for as long as they need to. And it's between the veteran and their individual clinician who, one, come up with a treatment model, but two, decide on terminating treatment when they see that they've achieved their goals. So I'm going to take a pause in case there's any questions, because I know I've thrown a lot at all of you, but if there's any need for elaboration, I'm happy to speak through that.
So let's review some of the points of differentiation then, as you're kind of contemplating questions about what is Headstrong and how does it treat and address the mental health needs of the nation's veteran families. I'm going to quickly kind of summarize the points of differentiation for you. One, to be served by Headstrong, it really is quite simple in terms of how we approach eliminating barriers to care. And I'll talk about those barriers which are pronounced within the veteran community. So one, we're cost-free. It doesn't cost anyone anything to be seen by a Headstrong clinician anywhere in the country. Now that puts a lot of pressure on us as a nonprofit to raise the necessary resources to be able to deliver this care and treatment at scale, but it's a point of pride with us that there are no costs associated with care by Headstrong. Two, Miguel touched upon it. We are not time bound, whereas a lot of other clinical approaches are really number of session oriented, insurance based. You can do this much, but not anything beyond. we've eliminated that. In fact, I would tell you that within our data, above 80% of our clients are with us long-term. And that's a good thing, because we find that within what is the Headstrong population we're serving, Miguel touched upon this as well, these are individuals with really chronic sets of co-occurrence or comorbidity or just co-occurring challenges in their lives. So these are people who serve their country, who are the family member of someone who served their country, and are dealing with chronic sets of conditions where long-term care and access to that care on an unimpeded basis is very important. And then the last thing I'll address is no stigma, right? We do a great deal of work to introduce vulnerability, to get people to work with their clinicians, and don't apply any judgment nor any discrimination to any facet of the veteran population. We serve people with good and bad paper. We do not discriminate between the two. So touching us in terms of eligibility to be seen by us couldn't be simpler. And we pride ourselves on the streamlined approach to getting an individual from point of intake to point of assessment to point of assignment with an individual therapist across the country at scale. So those are really the differentiating points between Headstrong and other organizations addressing the mental health needs of the nation's veteran families. So I'm going to turn quickly into the chat. There might be one question.
Yeah, Jim, there's a question from Steve talking about the referral process, and it's really easy. A lot of the point of entry to Headstrong really begins on our website. We ask very simple questions, mainly a method of contact for the veteran, that is for one of our intake specialists who is a licensed clinical social worker to reach out. The intake is primarily a way to assess what it is that's bringing the client to Headstrong. We don't go into great detail, but we do try to summarize buckets of trauma, so to speak, whether or not they were in danger, ever felt like their life was in imminent danger, had to see or injure someone. And then lastly, whether or not they grew up in a safe home. That's our quick way to assess a couple of things. The other thing that Jim and I wanted to briefly talk about is also, substance abuse, which is also often a barrier to care, which Headstrong has a higher risk tolerance for people who actually have substance abuse. We don't turn people away. In fact, all of our community networks have a part of the rollout is making sure that we have sufficient providers with either CASAC experience or a HAP reduction model to look at and work with veterans who suffer from or are dealing with substance abuse disorders. So for us, we that's a quick way to summarize some of the problems that we might need to address. And then from point of intake, they're assigned a one-time psychiatric evaluation within their market. And the psychiatrist is primarily geared and equipped to do two things. One, immediately assess the safety risk for a client. We would never bring someone into Headstrong who is actively suicidal or needs higher level of care. The other thing that it allows us to do is really actually get an in-depth view, maybe provide a couple of differential diagnoses that might help inform what the treatment plan might be. Oftentimes there are some other access to disorders that we have to take into account. So, the psychiatrist really helps us and the clinical team at Weill Cornell develop a tailored individual approach. So we look at which of the clinicians in network have the ability to respond and address the needs that the veteran has highlighted. And more importantly, are they within a specific geographic reach so that the veteran, it really doesn't have as many barriers to care, rather than having to go to one single, building 30 to 40 miles away. Part of what we do, in addition to assigning them to a therapist that has the right treatment approaches, but also one that's geographically proximal to ensure the highest level of engagement and treatment adherence. So that's the referral process. And then I believe Virginia has also a question about waiting period. Right now, currently, Headstrong doesn't have a wait period. I would say that, there is some variability in, from point of intake all the way up to the clinician. And that's largely dependent on the client behaviors. So whether or not they're ready to engage in treatment, their availability, a lot of them either are working or are in school, so their availability is often limited. But typically, I would say the average from their initial outreach to the website to being in front of their assigned therapist is about 7 days.
Yeah, that's a very good time hack. And Stevie has a question in terms of, do therapists work virtually? And this is probably a very good moment, now that we've covered the model and the specifics within it, to kind of pivot to our second objective of this conversation. And that is, what are the current trends and observations and issues we're seeing in the population we're serving? So let's just begin with the obvious. During a global public health crisis such as COVID-19, the traditional pathways into care have been disrupted. I myself, in the last 12 months, kind of turned to the VA after all the years of military service to get some help with a rough patch in my life. I went into the VA's behavioral health care line. When COVID hit, I got a phone call that I couldn't see the person that I had been seeing. And it was as if the world had ended in terms of behavioral health care within the VA. As they closed their medical centers, they had a great deal of difficulty transitioning to telemental health. And in fact, in my case, it wasn't even offered. I'm happy to tell you that Headstrong's pivot as COVID-19 was becoming a reality in February and March of this year, it saw us turn to an available telemental health platform that's PII and HII compliant that was available through our partnership with Weill Cornell Medicine. So all our therapists today are engaging with their clients in either a virtual mode using methodologies such as what we're using today, but in a confidential way, in a protected way. And that model now has become what we're referring to as the hybrid model of care, and where clinicians can see clients in person, they continue to do so. Where not available, we have delivered continuous care to our clients since the beginning of COVID virtually. And it's offered us newfound ground by which to reach new members of the veteran population that we otherwise wouldn't have been able to reach. The typical model of mental health treatment is you walk into a building, you see a therapist, you walk out, you make your next appointment, you go in for your next, right? So that entire world has been disrupted. And so our population, when you look at some of the issues within, from the kind of the difficulty dealing with social isolation, the pressures of economic insecurity and job loss, having children in the house with extended family members who might have moved in, to kind of shelter, if you will, during this period. We can tell you from a New York City perspective, many young people just went home. They haven't come back to New York City as their jobs don't require them, if they still remain employed, to work in offices. Our offices in New York City, we visit in frequently, and we do most of our work virtually. But our therapists are very adept at working over virtual platforms. Some of the observations that are associated with treatment virtually, I'll leave to Miguel, because he's closest to the flame, if you will, having an understanding of what's being seen by clinicians themselves as they're dealing with this virtual backdrop. So Miguel, back over to you.
Thanks, Jim. And again, part of what's interesting, or the silver lining in COVID, is really the acceleration of learning and adapting, some of the evidence-based therapies to be delivered virtually. And we have some strong evidence, that's coming out just from a couple of reports about the efficacy over CPT, PE being delivered virtually, as well as EMDR. And one of the great things about this model is that when you have a clinical partner with experts at Weill Cornell College of Medicine, making that knowledge exchange available to the network of 250 veterans happen seamlessly. So the adaptation of delivery of some of these evidence-based practices virtually helped a lot in terms of our transition and ability to continue to deliver service. What's interesting, and Jim mentioned, their initial concerns, and though they haven't really been abated, some of the initial concerns were that this increase in isolation, the anxiety associated with the economic job loss, the economic uncertainty, that there would have been this rise in an exacerbation of PTSD sequela. And what's interesting and what we've noticed is that, especially for some of the veterans, I would say about 40 to 50%, just based off some anecdotal observations, actually have found relief in the mandates for quarantining. And it's been an interesting observation because they have felt that either their military service or what they've experienced has prepared them for moments like this. Now, it's not to say that that the anxiety or depression is often associated with their combat history has been resolved. In fact, it makes it a little bit more complicated trying to address, and reprocess some of the more traumatic memories when there's this constant reinforcement of some of the things that they might have experienced. And rather than, experience some increased distress, some of them are actually often experiencing some relief because their symptoms have been almost validated. And by having a quarantine, by being prepared, by having to self-isolate, all mechanisms that have been maladaptive prior to COVID are now proving to be a source of resilience for a lot of these veterans. So the work is getting a little bit more complicated, right? Needing to address both what's happening concurrently with some of the trauma that they experienced definitely has challenged our clinical team to be a little bit more innovative. But the work continues, and we're proud that we're able to observe a lot of this, having the scale and scope, and that we're able to contribute to some of the knowledge exchange going on. I think there's a question from Christy. I don't know, Jim, do you want to field this one?
Yeah, and before I do, I want to kind of amplify a couple of points embedded within Miguel's conversation that just took place. What are veterans and family members telling us? So, what we hear from our clinicians are things like the following: that the ability to engage with the therapist, the ability to get into therapy cleaner, quicker, is certainly one of the things we've picked up on in this era of pandemic. Veterans will tell us, like, I no longer had to worry about taking public transportation or going from point A to point B. I'm comfortable in my living room. I'm comfortable in my dining room, having these conversations with my clinician. The downside of that, and this is what clinicians tell us, is sometimes they're engaging with a client who doesn't necessarily have the highest degree of privacy with family members, kids running in the background. We've heard stories of, hey, I'm at the Dunkin' Donuts drive-thru. Just hold on a sec while I get my coffee. And they're on the phone with a therapist for their regularly scheduled session. So as much ease as there is in kind of sitting in your own home or your apartment and coming online with your therapist, there are some distractions in the background that are not normally associated with an in-person visit under extreme, behind closed doors privacy. So it's a little bit of a mixed bag. It's easier to access therapy, but there are more distractions that are running concurrently within our clients that at times interferes with a continuous discussion from top to bottom. So here's a question from Christy. The services are free, but is it a requirement for the veteran to have insurance? No, Christy, it's not. No. In fact, 60% of our clinicians accept no form of insurance repayment whatsoever. And so our clinicians invoice Headstrong based upon the sessions that they offer month over month. We audit that, and then we simply deliver payment very quickly to clinicians. I will tell you that in the future, we're likely to, and let me back up a little bit. As we have this conversation with each of you, I really want you to understand that today, Headstrong is a group practice of highly trained, trauma-informed clinicians working at scale across the country. In the coming 12 months, in 2021, we will enter into a relationship with the VA and the DoD to offer reimbursement for VA-eligible clients, but it's not designed to go reimbursable directly to the therapist. As a group practice, we'll push the money to the therapist that it comes in from those sources to offset the cost of our care. And our cost of care is much higher than what you might associate with cost of care in several other settings. So here's a question from Virginia. Does Headstrong only serve veterans with service-connected disability, have combat deployment as part of service, or any other kind of service requirement? And we serve all those individuals, but it is not part of our eligibility criteria, Virginia. I said at the top that we don't discriminate around specific subcategories of eligibility, and that's one of the secret ingredients, I think, of Headstrong, is that we simply don't present those eligibility criteria as barriers to care. I can tell you for every combat veteran we have in care, we have non-combat veterans. We have victims of military sexual trauma. We have individuals who've experienced childhood trauma that's been exacerbated by their military service. We have family members who've suffered alongside their individual service member or veteran that have received care and treatment from us. So, and I'll give the next question to Miguel because they're coming in and I'm gonna kind of share the wealth here. But Miguel, do you want to address Joe's question?
So yeah, I see. The question was, do you help everyone who traditionally can get services such as grown children of combat vets, parents, siblings, and former spouses who divorced to the effects of war? I'm going to say that this is not a population of people that we do serve. Our mandates are for the veterans, post 9/11 veterans. There have been some discrete cases where, again, if the veteran is in care and this is part of the family system approach to improving the veteran's overall well-being, we will pick up family counseling, especially for children of the veterans as well. But it is for us our requirement that the veteran actually be engaged in care. So that is one of the ways we can serve veteran families. But it does have to start with the veteran himself, being him or her being in care, so that we can simultaneously address some of the family system dynamics that are contributing.
Yeah, and those are best described as adjunct therapies. Couples counseling, family counseling, neurofeedback. We've combined a lot of elements with the strictest sense of treatment modalities that Miguel talked about, such as EMDR, CBT, CPT, PE. Those treatment modalities are all part of the inventory of tools within our Headstrong clinicians. But along the way, we have offered those adjunct therapies. Now, I'll tell you, with COVID in mind, we've had to kind of go back to doing some very core work just based upon the incredible demands being imposed upon our clinician base at this point. It's no surprise to anyone on this call that demands are up from a mental health perspective for our population. We just did a clinical call a couple of days ago where we're seeing on average 100 new clients present month over month. So, we can tell you that in the backdrop, there's a great deal of need being expressed amongst our population, putting additional pressure on the organization. And as a result, we've had to kind of stick to the core of treating, the post 9/11 veteran, the active duty service member enrolled in our care, or the family member. So, our priority has been to deliver care for post 9/11 veterans. And that certainly has been what COVID-19 has kind of constrained us to doing, simply because the needs have been so great amongst this population. But we have every aspiration of, as we come out of COVID, returning to our pre-COVID stance of opening up the aperture to invite back in veterans of all eras, family members of all eras, service members and their families as well. So it's been this kind of really delicate balancing act in terms of the resources you have and the capacity you have to address the mental health needs. You have to pay attention to it very closely because, as we said at one point during our conversation with you, we have a lot of active clients under our care month over month, and disrupting their care journey is not something we're interested in doing. So our capacity to add new individual clients month over month is limited to about 100 a month, but that's kind of where we are based on COVID. So Miguel, do you want to provide Stevie's response, referral information, how to touch Headstrong?
Yeah, I can provide it to Melissa and Janae, who can send this out after our call. But there is a www.getheadstrong.org/get help. That is the quickest way to get to Headstrong. And again, it is a quick, only 3 pieces of information: name, contact information, and program market, that'll help us sort of really zero down and get the gears rolling in terms of getting them into the treatment pipeline. But we can definitely provide that to anyone after this call.
Hey, Miguel, what's the average, in terms of our clinical base, how many years of trauma-informed care do we typically look for in a clinician as we add them to our ranks?
Yeah, so part of the vetting and the choosing of clinicians, we are pretty intentional about who we bring on into the practice, into the network. They typically have to have at least a master's level training with 10 to 15 years plus of treating trauma. And it's not specific to veterans only. We quickly learned that for many of the veterans, what they care to be seen by, or who they care to be seen by, are trauma experts, ones who can help them sort of address some of the issues that they're bringing. We do provide additional military cultural competency to ensure that the care is sort of standardized and that people don't feel alienated coming to any of our therapists. But they at least have to have 10 to 15 years of experience treating trauma, and have at a minimum have EMDR 1 and 2 training under their belt before they can be considered for eligibility within the network. I hope that answered some of the questions.
Yeah, thanks, Miguel. So, and when you understand, the vetting process associated with our clinicians, you can begin to understand why we accept a greater degree of risk that other treatment practices might not entertain. And the fact that we deal with co-occurring substance abuse simultaneous to mental health treatment, that's a unique discriminator in the world of care these days, because in many circles, it's very analog. Get treated for your substance abuse issues before we treat you for your ongoing mental health needs. That is not the case within Headstrong's model. We're capable of dealing with chronic sets of co-occurring conditions, which I think further discriminates or further defines the points of differences between our organization and others. So it's always, and I'm glad, Elizabeth, you said this, and Elizabeth is thanking us as you've referred to our services often and always receive amazing feedback from veterans. And boy, on the heels of Veterans Day and leading up to Thanksgiving, there's no greater words of thanks than to hear from someone we serve that we're helping them. So I want to stress too that our markets are always growing. And so, there's a number of faces associated with these tiles present on this Zoom this afternoon. But if you yourself are a clinician and interested in becoming a Headstrong clinician, we're always growing our in-market presence year over year. So if any of you would like to talk to us about becoming a Headstrong clinician in addition to your ongoing practice, if that's the case, please just hit the website, give us a call. We'll take care of that, and we'll talk to you about joining as a Headstrong clinician. It's actually one of those things we're always in favor of doing, is trying to kind of fill the ranks of clinicians to the greatest extent possible. And I can tell you the Washington, D.C. metro area is one of our largest markets in the country. It's one of the most active. It has one of the largest client populations that we serve anywhere. And so growth in clinical capacity is always foremost in our minds. So we're about 15 minutes away from the end, and I want to quickly pivot to the last item on our agenda today, and that's to discuss the future of integrated care and support for the nation's veteran families. I'll begin this part of the conversation by acknowledging what the VA itself has accomplished in the last 24 months with the VA Mission Act of 2018. It in fact has afforded veterans the opportunity to receive care in community settings outside of the VA. And these community care networks that have emerged through the insurance carriers for the VA and the DoD, Optum, Optum Health, AmericaServes specifically for Optum Healthcare, and TriWest, they offer new mechanisms by which the nation's veteran population can access treatment and care in their communities. And that's certainly something that we see coming to the marketplace more and more. That's why Headstrong as an organization is going down this pilot path with the VA to deliver community access to high quality treatment adjacent to the VA. And I will tell you that a good number of our referrals that pass to Headstrong on a daily basis come from, in fact, behavioral healthcare specialists working within the VA who have a very limited set of tools at their disposal. In this world is not a one size fits all. So oftentimes we'll receive referrals from behavioral healthcare specialists within the VA itself who believe that Headstrong is a better treatment option for the veteran that they're trying to serve. Miguel and I returned from Seattle, Washington 2 weeks ago, I think, before this latest upward surge in COVID is occurring. We were out there just setting conditions for the opening of our Pacific Northwest market. We found in conversations with individuals at Joint Base Lewis McChord in Tacoma, Washington, about 30 miles south of Seattle, that Madigan Army Hospital, as a military treatment facility, is only dealing with the active duty population. The demands from a mental health perspective are so significant that what was initially envisioned as capacity to address the treatment needs of veterans and family members, it's not the case. And that is the case across this country, where military treatment facilities on base, on installation, are predominantly supporting our active duty population, and access to care through those facilities for veterans and family members is very, very constrained. And so what we find is a lot of referrals coming out of the VA, and this goal of developing more seamless integration between community care providers and those within the VA. In Seattle, there'll be an interesting experiment unfold where an ecosystem develops around nonprofit organizations, the VA and the DoD, where responsibility to get the individual to the proper point of care is expected by all delivering mental health treatment in the community. And so it layers onto us this additional responsibility, which in my opinion is a good responsibility to bear, to ensure that maybe the client who's not best to be served by our organization, we ensure that client is delivered to the next organization in line that is best suited to address that individual's needs. And certainly that's what EveryMind works very hard to do every day, with serving together. That's the model, right? The pattern of care becomes the gold standard versus individual points of care. And the responsibility to share clients across organizations based on co-occurrence, based on unique needs, is resident in all of us to address the system of care that has to emerge to be the best possible care that this country affords to people who serve their country. So we're big believers in the future of integrated care. We'll participate as a community-based treatment practice. We work with the VA daily. We work with other providers daily. The Cohen Clinic is resident in many of the communities we are. Slightly different model, time-bound, and our referral mechanisms back and forth are strong there as well. I'll give the mic back to Miguel for a second, but this is now a world where organizations are forced to do what they do best and stop stretching themselves to do things that they unnaturally wouldn't do, and get the individual to the next organization that is in line to do what they do best for the individual itself. One of the fundamental aspects of care that is emerging within the Veterans Wellness Alliance, run by the Bush Institute, has a lot to do with veteran-centered care, right? Patient-centered care. You've heard these terms time and time again. Slow to materialize, within the VA, but you can see the advent of that coming in the integration of care, treatment, and services, where a good deal more of this is being pushed into the community, and where individual choice becomes something that we hold dear, as we have in the healthcare marketplace in general. So Miguel, would you like to add anything about the future?
Yeah, I would say, telehealth services continue to offer, one solution to mitigate the sort of burden on mental health services. And while there is a growing evidence, an evidence base on the effectiveness of telehealth for numerous mental health disorders and vulnerable patient populations, I think one of the things in terms of ensuring the viability of this as a future stance is the community's need to overcome some of the challenges stemming from the assumption that there are a limited number of providers or clinicians who have the requisite training and experience to use a lot of these technologies. There's been innovation in training adequacy and internet connectivity. There's been innovation in broadband capacity over the last few months that COVID hit. More importantly, jurisdictional issues. And I think this is a point that we need to continue to explore in terms of state reciprocity agreements. And so being able to extend your reach, leveraging some of these changes to mandates governing licensure, I think is a key to ensuring long-term success in any of the community settings. So in addition to what Jim was saying, I would also challenge that a lot of you take a look at some of the changes to the mandates and continue to look for opportunities to leverage some of these clearances and guidance around state licensure and reciprocity agreements. So that's another part of the future that Headstrong is looking at as a way to continue to expand its coverage beyond the limitations of finite communities. So leveraging the telehealth movement that's occurring in this country, I think is really critical to the success of mental health in general towards the future. But Jim, I think that was the only comment I had left.
Okay, thanks, Miguel. Yeah, it's clear that telemental health is here to stay. Our model will remain hybrid. Our stance will be such that we deliver care virtually and we deliver care in person when appropriately. And we all hope that this pandemic is something we get beyond in 2021 as best we can. It's a very trying time for not only our clients, but our clinicians and our communities. And we're just trying to do our best to kind of address the needs as they emerge. We've got one question here at the bottom. So I guess before I address that, I think this probably ends the formal part of our discussion. We've covered the 3 objectives. We only had an hour to do so. We want to make sure that we address any questions remaining, but we have one. How many therapists does Headstrong have at this time? And right now we're approaching 260 licensed clinical professionals, ranging from psychiatrists to trauma-informed therapists themselves. Every program community in our model is supported by a psychiatrist and a supporting cast of trauma-informed clinicians with a great deal of experience, as Miguel talked about. So, and the plans for Headstrong between now and the end of 2025 see us expand upon our market presence to be resident in all 23 of the VA's veteran integrated service networks. And we chose that because what we found, the silver lining of COVID, when you're dealing with virtual or telemental health, you don't necessarily have to sprinkle your clinicians inside a community to serve that community. Miguel touched upon state licensure. I was a state commissioner before I got to Headstrong. Here in New York in March, we were dealing with incredible rates of spread with COVID-19, and Governor Cuomo and the administration relaxed certain licensure restrictions to include funeral directors, but also mental health professionals that allowed clinicians to practice across state lines. We know today reciprocity is one of those things that we're probably going to have to kind of instill within our clinicians as we grow to this stance of serving geographies versus specific communities. I keep going back to Seattle, Vision 23. It encompasses 3 states, Oregon, Washington State, and Idaho. Wouldn't it be ideal if you could position clinicians anywhere across those states, and through reciprocity, you were able to practice care and treatment at large? And we know we can knock down a lot of barriers that involve rural-based veterans who don't have access to in-person clinical assets, and where virtual engagement remains the preferred method of treatment to reduce time and distance factors. So we know this is all the future. We're pushing hard to continue to innovate in what we do with telemental health. And we expect to grow by 2025 to be resident in all 23 veteran integrated service networks that are maintained by the VA. And that's a pretty good statement when we can say that where the VA has medical center, infrastructure, and professionals, so too does Headstrong in an adjacent or supplemental or complementary way. So I think that's probably got 5 minutes left. Hopefully I addressed the last question by Sony. And we'll open up the net if there are any questions or anything you'd like us to address. We can do so now in the remaining couple of minutes we have. But thank you for your attention. Not seeing any emerge. Melissa, I'm going to turn the microphone back over to you and Janae and just simply say thanks on behalf of Miguel and I here at Headstrong. We wish you all a happy Thanksgiving. Stay safe, stay healthy, and we hope to see you under different circumstances with every mind as we continue to support the Washington, D.C. metro area. So Melissa, over to you.
Yes, I wanted to thank you both very much. I'll clap, and hopefully everybody can find their clapping emojis as well in the reactions. I'll just share my screen again with you guys one more time. Ooh, let me pull up the right slide. As I said before, or maybe I didn't, my name is Melissa Cumjan, and I am an AmeriCorps member for EveryMind, and I work in the education department, but I also work with Janae on these Serving Together programs. These are just some of the resources that I already think I threw in the chat, but these are the people that we work with and the websites where you can find more information about each of these fabulous groups of people. As always, we want to thank our presenters again for spending their day with us, taking time out to really highlight something very important to Serving Together as well as to our community. The last thing I wanted to mention, and I see the chat is got a couple things in it. I just wanted to make sure that I'm not missing anything. Oh, lots of thank yous. Thank you, everyone, for coming as well. But the last thing I did want to mention, my slide's not advancing, there we go, is please complete our evaluation. Hopefully you guys have seen a QR before. If you grab your phone and you pull out your camera, and you focus your camera on this QR scanner, that is a good way to get to our SurveyMonkey to complete our survey. I believe there is a question at the end if you need CE credit units, sorry, for this class today. And if you are having any trouble with that, Janae, her email is here at the bottom. I can put these things also in the chat, but I do have to stop sharing to find them. Sorry. So yeah, if you have got this scanned, that is excellent. I'm going to put the links in the chat real quick as well, and stop sharing so that if you want to get to it that way, that is also an option. But other than that, we really appreciate everybody who joined us today. We hope that you enjoyed our presentation, and a special shout out to Jim and Miguel for taking time out of their day to present for us. So, and I will not send this to Jim, I will send this to everyone. But yes, thank you so much. Hopefully you all have a wonderful day and a wonderful Thanksgiving, and all that information is there. And with that, I am done. Thank you guys very much.
Thank you, everyone. Happy Thanksgiving.
Right.
Melissa,
Yes.
the SurveyMonkey link does not work.
Well, that's weird. It worked for me.
It said there's nothing there.
Let me double check one more place and see if I can get you a different link. Hold on one sec.
Thank you so much.
Hopefully this one will work. I don't know why that's not working. That's super weird. Got a lot going on.
It's working now,
And
apparently.
I just got you guys the link. Thank you guys so much. Sorry about that.
All right, thanks.